Good morning. This is Dr. John Bennett broadcasting from Miami, sunny Miami. Day's just starting over here. It's 8 o'clock. It's 4:30 p.m. in Tyumen, Russia, where we're broadcasting live a skull-based surgery conference headed by Albert Sufyanov of Russia, notable surgeon, as well as Louis Borda and Ip Cherian. I'd like to say good morning to my co-host, Kathy Gifford. No, it's Simon Downs.
It's Howard Cosell.
Howard Cosell and Dandy
Always
Don.
great to be here. Dandy Don.
Okay, let me just go over the schedule here, what we're going to see today, and let me screen share for that. Okay. We haven't been hooked up yet with Victor, the Russian tech. Okay, it's okay, Friday afternoon. Okay, today, tumors, as you can see, let me just get this a little bigger so you can see it. Okay, this is Friday afternoon in Russia. Okay, at 4:30, giant vestibular schwannoma. At 4:45, tumors of the third ventricle, microsurgical approach with Marcelo Ferrara. The first one is by Kiki Turai. At 5, the challenging midline lesions from the hypothalamus to the conus of the spinal cord. Then surgical treatment of trigeminal schwannoma. And then with Wuditong Tiutakiai. Victor Dolan, the gentleman who's this conference is in honor of, is going to speak about the hypothalamus I mentioned. Then the facial and cochlear nerve preservation and large vestibular schwannomas, and the petrosal approach. So we have some solid presentations. What do you say about that, Simon?
Looking forward to it. I was wondering if Dr. Kimura will be presenting today. He presented yesterday.
Let's see here. Kimura,
I see him on the schedule. But he
okay.
Yesterday.
Is he on the schedule?
Yep, at 8:50.
Okay. Okay. Ip Cherian tells me that Albert Sufyanov wants to start a channel. He has a channel of videos, dog. Why don't you check it out? See,
yeah.
Well, maybe we can check it out.
Yeah.
Let me. Yeah, why don't you check it out? And Sufyanov, Albert, YouTube channel. Sufyanov, okay, Sufyanov, okay. Okay, let me put the link. Hopefully we'll be starting momentarily. Sufyanov. Okay, we're still waiting here to be hooked up. In the meanwhile, looking for Albert Sufyanov, his channel, so that we can add it. You know, ideally what we want to do, dog, is we want to connect the research centers, neurosurgical research centers around the world. We can easily connect them at Neurosurgical TV, easily.
Mm-hmm. Yeah.
Easily. And it would foster collaboration and communication between these research centers. And we certainly like to bring the rural center and Tayumen of Albert Suvianov. We like to bring that into the fold.
Yes.
You find the dog, the channel?
Nope, I didn't.
Okay. Let me ask. I. Okay, we'll find that channel there. We're no. As my co-host, Mr. Dr. Downs, we have to fill this with educational material. So I'll
Right.
let you start off.
Okay. Let's start with the wind-up of Monday Night Football.
Yeah. Well, we're talking about schwannomas. We're not talking about Dallas. Schwannomas and other various lesions. But yeah, we've had very good video quality, very good sounds.
Yeah.
The potential is
Great
awesome.
presentations too. Excellent presentations.
Excellent presentations, and we have to learn how to. Well, it's just a matter of a camera hookup because Victor was able to give a really good connection video wise with his setup, and I think I got an echo here, dog.
Yeah. Oh, really?
Are we opening more than one program here? Let me check here. Maybe I am. No. Are you open it too? Okay, I guess we're.
Yeah.
Okay, there we go. It's down.
Okay.
Okay, that's good.
One thing I noticed yesterday was that the presentations were generally short, like 15 to 20 minutes with questions, which I thought was effective.
Yeah, that's they didn't have questions the first session, but they allowed questions the second.
Yeah.
And it seemed to go well.
Yeah, really.
And I think there's a good amount of Russian people there because during the breaks, the moderator speaks Russian. And I have no idea what he said. Yeah, he speaks Russian to the audience.
And they had simultaneous translation.
No.
I noticed for Dr. Kimura, he was wearing an earpiece, and he was.
Oh, really?
Yeah, simultaneously. Yeah.
Oh, okay. I don't know.
Yeah.
I didn't notice that.
In English.
We're gonna start now. The Facebook Live, and you'll be able to see it live because everybody has a smartphone.
Yep.
You can simultaneously broadcast to your audience and interact with the audience live, because once the presentation starts, obviously the camera goes off. Us here, we have a couple of messages here. Let me get this rolling here. Okay, live. Okay, I'm describing my video. I'm going to live Russian conference. Skull based. Quote mark. Skull. Skull brace surgery. Why don't you tell the huge audience out there, Dr. Downs, about your plans tomorrow?
My plans tomorrow. Well, I'm taking an entrance test for Japanese medical school, transferring my
Oh,
credits to
we all rue the days of those exams.
yes,
Pressure
very exciting.
packed days.
Chemistry, biology, physics, mathematics,
Wow.
English. English is my strongest subject.
Oh, you speak excellent English, by the way.
Thank you. I practiced for this interview,
Okay.
but and then there'll be a Japanese interview too. So it's going to be a fun-filled day.
Oh, you're getting tested in Japanese too?
The interview, I think, will be bilingual.
Okay.
So we'll see how that goes. Yeah, starting
3,
in a few
2,
hours.
1. Okay. Simon, we are
Yes.
now broadcasting live from, let me see, live on Facebook for the Russian conference. Any Facebook followers? Oh, there you go. Who's that on there? Is that you on there? Howie Cosell. Let me see
Yeah.
the message that George Lakis sent and we have an Algerian neurosurgeon, Abdurrahmi Chek.
Mm-hmm.
We'd like to bring him into the fold
Yeah.
because currently certainly incorporating neurosurgeons from Algeria into innovation center like Tayuman, it would be beneficial.
Yes.
Okay, we're a little delayed on the transmission. We're still waiting for that to come on. And okay, let me go back to the live here transmission. Okay, here we are. Here I'm showing the Facebook crowd. And the good things. Hi, Santosh is watching. This is behind the scenes here. And Carlos is watching from Spain.
Okay.
And Amar is watching.
All right. Getting ready to go. Ready to roll.
We haven't gone live yet from Russia, but we're behind the scenes. And there's Simon. Say hi to the Facebook crowd, Simon.
Hey, Facebook.
It's only a couple of Facebook people. But the convenience of the Facebook is that once you begin this broadcast, you simultaneously
sports fans.
You simultaneously see who's watching. And Carlos, if you want, let me know. You can message me. Greetings, Carlos. You can send a you can send a message, Carlos, if you want to join us here in the panel. I don't know how much time. And my brother Billy's watching. He's probably working on the ocean. Billy says, "Hey, Bill, we're televising a conference from Russia. We had Kurt on yesterday, but he didn't like the panel because there were no women." I don't know. Billy says, "Yeah." So these people watching on Facebook can actually text you.
Yeah.
And this might actually be another way to communicate. Like something's not showing, or there's something technically wrong with the transmission.
I see it.
Yeah, I would be able to see this. And I'd like to put I think I have to click up my plasma to the internet because I think that'll be another way to televise it. Because I do have 2 IPs here.
I wonder if I say hello, can you see my hello? I just messaged you hello.
Yeah, Simon Downs is watching.
Okay.
There we go. Hello. Yeah.
Okay.
Yeah, you just wrote the message in below the video, right?
Oh, yeah.
Yep. And Santosh shared it. Hi, Santosh. Thank you. Santosh works with IPE, and I believe he's located in Kathmandu. He helped us put this transmission together and sent it out to the ACNS members. And greetings to the ACNS members out there. You're welcome to join the channel. Santosh, Albert Sufinov wants to create a channel. Well, that'll be nice. That'll be nice. Thanks for the thumbs up, whoever gave it. So we're still waiting for the broadcast to start here at Neurosurgical TV. And I can see the broadcasts are filled with dead time. But the Facebook Live is very informal. Very, very informal. It's one like transmission, but I like it. I'm going to send you a link, Carlos. I don't know if you can join us. Carlos is a medical student that's from Mexico, but he's currently in San Carlos Clinic in Madrid,
Okay.
Spain.
Welcome.
One
Welcome.
of my favorite hospitals. Hopefully, we once televised a conference from San Carlos on neurointerventional radiology, and we hope to televise many more events for our Spanish audience to incorporate them in the avid followers of Neto Cirugía TV. This Simon, what are you giving likes on, right? It's kind of clicking all over the place. Thank you for our self-congratulatory. Nothing like congratulating yourself.
Yeah, there you go.
The thing about transmitting on during the week, you can't get many people to come or jump on the panel. Like I think probably Carlos. I'm gonna send Carlos a link, but I doubt if he can join us. He's probably on the way to the hospital for his day. Oop.
Yeah, the phone fell off.
Oh, it's back now.
Okay.
There's a little delay there.
Right.
Okay, now I want to send this to. Where I want to send this to. Oh, Carlos. Okay, Facebook. Yeah, I'd like to make an announcement. We're going to have on the November 5th and 6th on Neto Cirugía TV, our sister station for Latin America, for Spanish-speaking people. We're going to have a Carlos. Is this Carlos? We're going to have a neuropathology, mostly pathologists. Most of the neurosurgeons were kind of hesitant to join us for that. Okay. Have you met Carlos, Simon?
Yes.
Okay, he's got the link if he has some time. I think it's middle of the day in Spain. But you can always come in, Carlos, on your smartphone to the Hangout on that link. One thing that people don't realize is you can conduct. I've actually conducted official Hangouts with people on smartphones, and actually, I got to make my banner here for Neurosurgery TV, which I should have done before, but we're not on air yet.
Short delay, huh? Maybe a sound problem?
Yeah, I don't know what the problem is. Okay, setting my banner here, Neurosurgical TV. Okay. There we go. See the banner dog, right? We are official.
Okay.
Yeah, they've been a little and I'm going to post this in MedStro. It's a big doctor service in Boston, Boston area. Let me copy the.
What's MedStro been up to?
Been quiet. I haven't heard much from them. They're still, networking in Boston.
Hmm.
Uh, haven't heard from Jennifer Joe at Alia.
Hmm.
They're doing their thing, like most people on the internet. You kind of get into your little niche and do your
Hmm.
thing.
Yep. Right.
But let me just go there and post it. I have no idea whether they have an audience there. But we posted her anyways. Yep, and then we posted in Medstro. Oh, we got to put the banner. I hope they haven't forgotten about us.
They have the link, I take it.
Yeah, I sent it right to Victor. Yeah, I always get nervous, but they come on usually.
Hmm.
Every time it's been slightly delayed. Time and Rush. Okay, it's posted on medstro.com. They do a lot of televising events around Boston. Yeah, Simon, we have a conference November 5th and 6th on Neurocirugía TV. It's in Spanish,
Okay.
and
Great.
I'm not sure of the speakers yet, but we've had interest of a couple of pathologists. And one of the things that I'm learning from televising these conferences is that it's best to get the person committed to speak, because I'm giving secret lessons here on Facebook Live. Because unless people put their pen to paper and commit, it's hey Carlos.
Who's the organizer?
The organizer is Carlos. Carlos from the medical student I was telling you about, Salgado, from Mexico
Okay.
City.
Okay.
He seems to feel that he can bring some Spanish neuropathologists into the fold,
Hmm.
which of course I'll be excited to work with Spanish neurosurgeons, because we'd like to get
Yeah.
them. Like to get them into the participants,
Yes. Yes.
and the European neurosurgeons. Um, so and he's probably the majority will be from Latin America. And again, it's just interest. Nothing on the schedule yet.
You have a title?
Yeah, neuropathology,
Okay.
neuropathologia,
Oh,
which I was.
oh, yeah.
When I talked to Victor, I thought Victor would jump at the chance. Victor Hugo Perez Perez, the noted neuroanatomist from Mexico City. However, he says, well, that's not my field. That's more pathologist. So we essentially will have pathologists that, naturally dabble in neuropathology. All pathologists do. And we won't be getting neurosurgeons. It seems that Victor, like some neurosurgeons, dabble in anatomy because they do it so much,
Mm.
but apparently it doesn't happen. I don't think you find
The other way
many
around.
neurosurgeons continuing to dabble in
Mm.
neuropathology. They probably took it as a course, but
Mm.
they just let it aside,
Mm.
and then they leave it to the pathologist.
Mhm.
So I think, like most neurosurgeons read their own scans.
Mhm.
I doubt if they read their own slides.
So the pathology is specialized into neuropathology.
Yeah, I guess there are some.
Okay. Specialized.
And I have no idea what type of pathologist we'll get, because there can't be too many just neuropathologists. But there are some that probably have a liking for it. Hopefully, will reach them. And the crowd is in Spanish. Now let me see the audience here. We just have a couple of people, but how many Facebook followers you have, Simon? Because it's just
500.
you and my brother watch it.
Okay. Well,
That's all.
I mean,
Everyone's busy with their schedule. They're getting on with their day, and that's why. Oh, I accidentally ended the broadcast.
oops.
Ended. Well, I'll start that later.
Hmm.
Yeah, it's just broadcast. Okay. I tell you, Facebook. They asked me, "Are you sure you want to end your broadcast?
Yeah.
Please come back." They don't want you to end it. I mean, the bandwidth those guys are gobbling up. It's amazing.
Mm-hmm.
And
And the data. I mean, they
and right now, let's see. Finish. Okay, I gotta put. No, I don't know. Can you see it now? Is it live now to you?
let's see. No, I don't think so. No,
It
it's
says.
off.
Oh, it says live to me.
Wait, it does say live, doesn't it? Yeah.
Yeah. Yeah. Refresh it because it ended. You got to be careful with what you touch on the smartphone because it'll go off. And you can't watch this anonymously. Like in other words, if you go on your Facebook, I see your name automatically.
Yeah.
So this
Oh.
is not the kind of thing you want to peep
Mm-hmm.
or watch from the background. You want. And once I saw this broadcast, there are. I don't know what's going on. Yeah, they're a half hour late. Well, I don't know.
Can you contact Victor?
Yeah, well, no, that's a problem with. We have no communication over there. I can send an email. Let me send an email to Anna saying what's going on.
No telephone number. Mm-hmm.
No. Oh, okay, Anna. I think she's works. Oh, no. Okay, workshop is still on. No lectures just yet. Okay, thank you, Anna. Okay, dog. You have to just edit all this out, I guess.
Okay.
It'll be an easy edit though. Just.
Yeah.
Just.
All right then. Maybe I'll come back later.
Yeah, she said the workshop's still going on. That was nice of her to do that.
Yeah.
Yeah. I think we'll. I'll mostly concentrate on doing. No, I wrote to well, this is going to be off the record, right, dog? So this is being. Well, actually, this is being televised. I guess I should stop the broadcast now and then stay on. Yeah, let me. Well, that'll mean I have to. That'll mean I have to send all of the URL around to everybody again.
Yeah. Right. Be careful.
Yeah, all the social media, the URLs up there, so we'll stay on.
Yeah.
We'll cut this off. But I've been approaching the conference companies.
Mm-hmm.
No, just one yesterday, a big conference company. But I think that we need to go after them, conference companies. So after your exam, if you have time, research conference companies.
Mm-hmm.
And neuro, I don't know if there's any that specialize in neurosurgery, but it seemed that they would be a natural fit, really, if they want.
Any more communication from the company we met online?
Oh no! Because essentially I left it at. I'll try to get someone that'll get speakers in some area of neurosurgery.
Mm-hmm.
I'm thinking of the interventional radiologist in January to approach Lewis, because when I talked to Dave briefly, he said that he may not do it. He may not do it. So maybe I'll approach Lewis and say, "Hey, we'll do it, and let's try to collaborate with this other company."
Mm-hmm.
But I've got to show you this website, dog, for neurointerventional radiology. It's really well advanced, based in Paris. These guys are very organized. very organized. And they've got they probably got the field locked up. And I want you to look at their website. It's an excellent website. That they don't live broadcast. They post videos, and the neurointerventional radiologists can post cases. And maybe there are people from other specialties that do it, allow you to post cases, but it seems to be a great idea.
Yeah, sure is.
So Singapore, okay, links. Well, I guess they do. Okay, yeah, okay. Here, I'm going to screen share their website. And you can see that website. It's called LINC, LINNC. It's an online reference source for the interventional neuroradiology and neurosurgery community. The neurosurgery community. So I'm going to approach them, saying, "Hey, we can live stream. We want to put on your site live stream conferences." But I have a feeling we're going to have to put in some ties for them. Everything, they all have ties on and stuff. But it won't hurt to approach them to see. But look, you get a chance. Look, it's. Hey, I'm going to give you a.
LINNC.com. I got it.
Yeah, I'm going to give you in the chat, in your Google chat, the address. But it's they advertise seminars. I think they're based in Paris. It's a neurointerventional radiology, but they also do neurosurgery, so they may be interested in collaborating. But as you can see, their website is cases that they post cases of neurointerventional radiology. Maybe they do it in neurosurgery too. But it's a good idea.
Yeah, this look good.
Yeah, you learn some things. I'm going to go this and learn some stuff. They post cases, but you can easily do them for neurosurgery too.
Yeah, that's good.
It's an idea of letting neurosurgeons around the world, like from Afghanistan, lectures.
I see. You have to sign up if you want to see them.
Yeah, I imagine so. But presentation of a case. This is a good idea. They present now. These are not live. I think they basically post a case. I don't know. I know they have one big conference a year, but I think the rest of the year this site. Yeah, it's an excellent site. Excellent website.
Look at those videos. They're great. Many too.
Yeah, they're good. So these guys have been around for a while. Reviews. And it looks like, look at Philips is advertising on their site. Hirokai Niki, is that the gentleman's name? He's from Japan. I'm sure there are a few neurointerventional radiologists from Japan too. But I know there's a couple of neurosurgery ones. So I don't know. Maybe they might be interested in getting the live streaming on. But we're getting there. Yeah, we're going to edit this out, right, Doug?
Yeah.
Yeah, okay. But it won't be edited out of Facebook Live, raw. Yeah, am I? Oh, I'm screen sharing. Okay, let me get off screen sharing. Okay. Have my morning Joe.
Yeah.
It's morning over here.
Oh, it's 9 p.m. here.
Richard's having a problem with his neck.
Oh, yeah?
Yeah, this is as you know, he's got a disc,
You
and
do surgery in
he's
November,
getting
right?
numbness to the hand. He's getting a spastic hand.
So November is set, right?
Yeah, November 1st, and he doesn't want to move it. He said you schedule so unless it's catastrophic, like he paralyzed the one side of the body, I don't
Mm.
think he's going to move it up. Um, so yeah, the state of what do you call it? The standard of care has changed in a ruptured disc.
Yeah.
Apparently, because when I trained in my day, it was basically because he's doing a fusion. To
Mm.
do a cervical fusion, you had to
Yeah.
take bone chips from the hip,
Right.
and I have no idea whether or not it's still done. However,
Mm.
this neurosurgeon says my impression when he talked was standard of care is putting a plate
Mm.
between the two,
I see.
and it's quick because most of those operations took I think around 3 or 4 hours.
Yeah.
But now he said an hour and a half and they're done. They put
Mm.
the plastic disc between the discs and they put the plate. They're done. An hour and a
Wow.
half. The anterior approach,
Mm.
the carotid that goes through.
Yeah.
And however, he said that if it doesn't work, that he's going to go in through the back and cut muscle. Once you start cutting tissue,
Hmm.
it adds time and recovery time to.
Sure.
Okay, I don't know if this is working. Okay, finish. I'm going to finish that ending. Okay, I just ended that. I'm posting it. Oh, okay. Here's Richard. Here's Richard now. Hey, Richard. Hey, we're live from Russia. I'm talking to Simon now. You want to come on a hangout? Where are you at? We're not. We're not. Oh, cool. You got your palm with you. You got your Surface with you. Okay. Really? Say, send it to me. Send it to me. Really, we should make a case presentation of this because this is an educational experience for neurosurgeons of the world. You know, your steroid. Yeah, right, right. Well, yeah, probably. Well, are you out of it now? Yeah, was your last day for it? Well, take it one day by day. Well. Has it ever been this bad before? That's probably has that. Yeah, that probably has something to do with it. It probably has something to do with it. Yeah, yeah. That's got to be it. Yeah, maybe you should back off on the tennis until you get it done. Uh, he may have. Well, maybe. Yeah, yeah. No, just hold off. Just hold off a couple of weeks. That's all. That's all. That's all. Yeah. Well, you can go without tennis. Yeah, yeah. You've gone without tennis for a large part of your life. Yeah, yeah. Give it up. Become celibate. So, how was the meeting? Good. How was the meeting? Good. Yeah. Isn't it amazing how good you feel when you go to a couple a day? It's incredible. Yeah, I won't be either because I'll be doing. Yeah, I won't be. Will be televised. Yeah, yeah. Well, the organizer of the conference wants to start a channel on neurosurgical teeth. Yeah, yeah. It's good to incorporate all these research centers around the world. You can easily do that. Yeah, you can easily do that. Yeah, well, you can easily do that. It's not, all it takes is just connecting the dots. That's all it is. It's not as I would say it's not brain surgery, but it is brain surgery. You know that phrase you say it's not brain surgery. Well, it is brain surgery. Yeah, that's right. That's it. Yeah, matter of fact, it is. Yeah, 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 yeah. It will. It will. It'll come. It'll come. It'll come. We like it, and we're okay now, and we're continuing to develop. Yeah, well, Benji, well, you don't probably don't want to drive now too much with your hands. Probably not a good idea. Yeah, yeah. Oh, okay. Well, where do you park your car? You have parking spaces? Oh, okay, okay. So, because yeah, you're. Oh, really? Okay, okay, okay. Okay, yeah, I'm gonna go to the noon again. Hey, listen, Richard. At the noon meeting yesterday, there had to be 4 or 5 girls that could have been worked at Mangoes. I mean, it was like, yeah, it was incredible. I couldn't believe it. No, he would have went fucking. He would have went into a feeding frenzy. He wouldn't know which one to go for. It was like, well, the meeting was unreal. I couldn't believe. I said, "Holy!" Maybe it was just a day, a lucky day. But I was thinking, "Wow, I've been there before. It's never been like this." And yesterday it was just like, "Holy!" The speaker was gorgeous, and there were 4 other ones in the audience that were just gorgeous. Yeah, I said, "What the hell's going on here?" But no, no, I'm just a peeper, a peeper. That's all. That's all. Just window shopping. That's all. That's all. No, no, no. I can't do it like Mark. I'll say one line and it's over. Yeah, Alfredo would have went fucking. He would have known who to hug. He would have known who to hug. He would have jumped from one to the other. You know, Yeah, it's like showing a dog, like a hungry dog. It's like putting 4 or 5 dishes. They don't know which one to go for. They just go one from one to the next. Yeah, yeah. I'm going to the 12 today. Why don't you go to the 12 today? Oh, okay. Well, you might go see the doc. Well, whatever. You guys work it out. Did you call his office or you call his cell? Okay, whatever. Okay. Okay. Yeah, no, that's a good way to do it because that allows his nurse to say, to tell him while he's seeing a patient, and he'll get to you when he's. Yeah, right, right. As soon as he can. Yeah. Well, he's responsive. Some doctors aren't too responsive. I'm sure you've had doctors too that are not. Yeah, he seems good. Seems good, and your life may change. Hopefully, keep your fingers crossed. Yeah, yeah. You don't.
Okay,
Oh,
so this is my
hold
first
on. We're
lecture
trying
during
to
this
telecast. I gotta go.
session.
Okay, see you
I've been
later.
here. This is my fourth visit, and I'm very happy to see my colleagues and, of course, the Russian neurosurgeons. I will be talking to you on giant vestibular schwannomas, and I thank you, Professor Albert, and the Federal Center of Neurosurgery for this invitation. Let us talk about giant vestibular schwannomas. Schwannomas are benign tumors in a malignant location, but we have seen progressive improvement in the results of this surgery because of microsurgery, intraoperative monitoring, imaging innovations, intensive care, and progressing radiosurgery. As you know, acoustic neuroma problems are of diagnosis, of treatment, and of the outcome. The problems of diagnosis are the clinical symptoms, the problem of diagnosis or interpretation of the imaging, and diagnosis which is missed very often by the ENT doctors. The ENT doctors are the people who usually see these patients first. So they should be careful enough not to pass off this problem of hearing and tinnitus as something to do with the ear. Then comes the problem of treatment overall. Should we be observing the patients? Should we be doing surgery? Should we be using radiosurgery? Or should we be using radiosurgery after surgery? And the other discussion is on outcome of these tumors. On one hand, we have the tumor, we have the problems of balance, we have the problem of facial nerve, problem of occipital pain, problem of hearing. So these are the issues that are confronting us as general problems in acoustic neuroma surgery. What are the aims? No mortality, complete tumor excision as far as possible. There should be no recurrence. There should be preservation of facial function. If hearing is already there, then we have to preserve hearing. There should be no neurological morbidity. And all the cranial nerves that are around the nerve, fifth nerve, sixth nerve, seventh nerve, ninth nerve, 10th nerve, they should all be preserved. And there should be no operative morbidity. So this is ideal. This is utopian philosophy. There should be, all this should be present. Then you can call yourself as an acoustic neuroma surgeon. But this outcome, such a brilliant outcome, depends on many factors. Patient factors, which I mentioned over here, age and general condition of the patient, the tumor size and morphology, and how badly the tumor is adherent to the brainstem and to the cranial nerves. Then there are surgeon factors, the surgical approach that he uses, the technique and the skill and the expertise of the surgeon. Sorry. What happened? And the management of the vessel and the cranial nerves, the technological problems, the technological problems are the problems that means you must be accustomed to using the microscope and the micro instruments, and you must be accustomed to using high-speed drill. CUSA is very useful, and electrophysiological studies today during the operation are mandatory as far as it is possible to have. So these are the factors which will control our results. However, the principal factors, if you make it into a small summary, which govern the results are preoperative deficit, what is the patient's condition before, and what is the size of the tumor. We see that smaller the tumor, better the outcome. Also, there are relevant tumor factors such as tumor vascularity and the arachnoid plane. These are two very important governing factors intraoperatively. Jackler had staged a system of tumors, calling them as Intracanalicular tumors, small tumors, medium tumors, large tumors, giant tumors. Intracanalicular means confined to internal canal. Small means less than 10 mm. Medium is 11 to 25. Large is more than 25. And giant is more than 40. In fact, this talk has been made for tumors which are more than 40, but we will cover everything in general. You must realize that when we talk about the size, we are not just talking about, let us say there is a 1 centimeter tumor is only 1 into 1 into 1. But when you increase the tumor size by 1 more centimeter, you make it 2 centimeters, the volume becomes 8 times more. If the tumor increases to 3 centimeters, it is 3 into 3 into 3, which makes it 27 times of 1 centimeter tumor. And if you have a giant tumor, it is 64 times or 8 times the size of the original tumor. So you can imagine the greater the size, the greater will be the impact of this tumor. So it's not only increase in 1 centimeter, but increase in 1 centimeter in all 3 dimensions, increase in volume. In posterior fossa, we have 3 compartments: the upper, middle, and the lower. And this was very nicely done by Dr. Albert Roton. He divided this compartment into arteries, brainstem, peduncle, cerebellar surface, fissures, and cranial nerves. Anatomical structures in the upper compartment is superior cerebral artery, midbrain, superior peduncle, tentorial surface of the cerebellum here, mesencephalic cistern, and the cranial nerves were 3, 4, 5, 6. The middle compartment, which is really the compartment from where the vestibular schwannoma arises, is the pontine area, middle peduncle, petrosal surface, pontine fissure, and 7th and the 8th nerves. And if the tumor grows lower down, it's the medullary brainstem area, inferior peduncle area, suboccipital region, cerebromedullary cistern, and 9, 10, 11, 12. So when you have a giant tumor, you can imagine all these structures are affected. So the problem is gigantic. So what does a giant vestibular schwannoma do differently from a small one? Small tumor will only, intracanalicular tumor may only produce hearing loss, tinnitus, vertigo. As it grows a little larger, becomes cisternal. Hearing becomes worse, and there may be a little disequilibrium. When it starts compressing, the next stage, it produces headache, and it can affect several nerves in the neighborhood, particularly the facial and particularly the trigeminal nerve. And as it grows much larger in the giant size, it starts compressing the fourth ventricle, produces hydrocephalus, and produces signs of intracranial pressure, headache, vomiting, papilledema, and mental changes. The removal of vestibular schwannoma of any size is considered to be one of the most difficult neurosurgical operations. And giant vestibular schwannoma poses gigantic problems. Size, of course, matters. I will not discuss this problem of bilateral acoustic neuroma because they are a completely different challenge, and this cannot be compared with a one-size unilateral large tumor. As you can see, it completely distorts the brainstem. You cannot see the brainstem. Where is it? By these 2 kissing tumors. But this is another story. We will not talk about it today. Clinically, the patient presents with brainstem compression, cranial neuropathy, hydrocephalus, tonsillar herniation, as I already said. What are the principles? General principles are of the approach and debulking. We must stay inside the arachnoid plane. Then there are general problems like displacement, compression, adhesion of vessels, brainstem, cranial nerves. And then we will go in this lecture to talk about challenges. Challenges of complete removal, challenges of cystic tumor, and tumor growing in spite of radiosurgery. So this lecture will quickly go through all these 3 problems: general principles, general problems, challenges. There are many approaches described. The middle fossa was preferred by William House and his group. Translab is also preferred by ENT surgeons. The neurosurgeons usually operate by retrosigmoid route because they are very comfortable. It's a common approach and it gives you a complete orientation of the tumor from all sides and with good scope of preservation of the eighth nerve also, especially when the patient's hearing is not lost. You can't do translab if the patient's hearing is intact. Okay. Craniotomy is done by exposing the borders of sigmoid and transverse sinuses. This is exactly the place. This is the point when you start making a burrow, you make a burrow on asterion. Asterion is over here, temporoparieto occipital suture. And usually if you feel the back of your head, you'll feel a small depression there. A small depression is always there in everybody's head. And that's the point of the asterion. So you make a burrow here, and then you can do a craniotomy. About 3 centimeter size craniotomy. What is the goal of acoustic neuroma surgery? Goal is preservation of cranial nerves. Aim of the operation is to preserve cranial nerves. Tumor removal is a byproduct. Whether you can remove it completely or partially is not as important as preserving the cranial nerve function. Please remember, this is the goal of surgery. So the technique is tumor debulking. You always make the tumor, large tumor small, small tumor smaller. You start from the center and shrink it from all sides. Remain inside the arachnoid so that you don't see anything outside, no structures. If you remain inside the tumor arachnoid, you will not see anything. You will not see any cranial nerves, you will not see the brainstem, you will not see ICA, nothing. But it's very important to stay inside the tumor arachnoid. And how you use these instruments for debulking? CUSA, tumor forceps, dissector. I do debulking in 2 stages, the major debulking first, and then finer dissection closer to the nerves. So, hello, video. Okay. So here, the cerebellum has been retracted, and I'm using CUSA. I'm using the dissector as I come close to the brainstem. So that's the rapid debulking. You must be careful when you're using CUSA. Do not go to the periphery of the tumor capsule. Otherwise, you will go through it and through the arachnoid, and you can damage the nerves. So always leave a small shelf of capsule around. Then you come to the finer dissection, closer to the nerves and blood vessels. The general problems, I think we missed that video. The general problems will come again to it. Can it possible to go back to the video? I don't know why we didn't get it. Okay, so finer dissection, as you see now, you can see very close. I'm close to the brainstem. I'm removing the tumor capsule very gently, carefully, away from the pons. I'm lifting up the tumor. You can see how deeply indented the pons is. You can see the pontine vein, deeply indented. So that part you must remove at the end. First you remove the major part, make it small, and then remove the shelf of the tumor at the end. The problem is of displacement, compression, and adhesion of blood vessels, of brainstem, and the cranial nerves. ICA is the most displaced blood vessel and its branches. The other vessels are petrosal vein, superior cerebral artery, mesencephalic veins, brainstem perforators. Please remember not to coagulate anything. Don't coagulate any blood vessel, excepting something which is coming from inside the tumor. Do not coagulate anything outside. Also preserve the internal auditory artery. Stay inside the tumor arachnoid all the time. So, staying inside the tumor arachnoid, now here I am seeing the ICA because the tumor is very large and displaced. So ICA is being seen. You can see very carefully the ICA artery. Now you can see the ICA over here and see the branches coming out from the ICA into the tumor. Many of these vessels are not supplying the tumor. They are only stuck. They are only stuck to the tumor. You can hold it and peel it off. Do not coagulate them. Just peel it off. You can see them. you can take them away. You do not sacrifice these blood vessels unless something is entering the tumor. So you can see the large tumor displaces the ICA and the blood vessels, and then you have the brainstem veins. Okay, so brainstem vein preservation. Be careful because you can otherwise have a pontine infarct. You have to be very careful as you take out the last part. Sometimes the arachnoid is so adherent to the brainstem, it may be difficult to separate. It may be very difficult, and sometimes you may have to leave a tiny bit of tumor attached. Also preserving the internal auditory artery. Can you see the artery on the surface? See the artery on the surface of the tumor. This artery is supplying the facial nerve and the auditory nerve. You cannot coagulate this vessel, otherwise you have a facial loss and a hearing loss. So addition to the tumor, separation of the tumor from the pons can injure the pons directly or indirectly. I'll give you an example. You can see a large acoustic tumor. You can see the edema around the tumor. You can see the edema around the tumor. This is a bad sign. The sign that there will be probably no blood-brain barrier has been disturbed, and there will be no arachnoid, clearly separable arachnoid. So you have to be very careful about this kind of a sign. You see the wetness around the brainstem. This, you must be very careful. You will have some difficulty with this kind of tumor. And you can see that now when we are operating, the tumor is being lifted. Always you lift the tumor from the bottom. So there we are. The dura has been cut. We are doing the tumor debulking. You can see now the tumor is being debulked. I'm going through all the steps again. We are staying inside the tumor substance, taking the capsule away, opening the canal. Canal can be opened at the beginning, in the middle, at the end, depends on your comfort. And then keep on irrigating. The assistant's job is to irrigate. And the surgeon has to operate with 2 hands for dissection. The assistant has to, now you can see how the tumor is separated out. And now you can see the brainstem and the facial nerve being preserved. And that is the okay, so we go to the next slide. The next slide is adhesions. Giant vestibular schwannomas are always very densely adherent to the brainstem. And you see over here how this is an operative picture of how badly stuck the adhesions are. To give you one example, this is a patient who had this pontine infarct following the surgery. Can you see this dense adhesion? This infarct, pontine infarct at the time because of the adhesions. Preoperative cranial neuropathy is a sign to indicate that you can have a worse outcome. If you already have a facial paresis before the operation, you may have a facial paralysis after the operation. So be careful about this neurological sign. Managing the 7th and the 8th nerve complex, first identification and then dissection. You must understand that the 7th nerve lies caudal to the origin of the 8th nerve. It rises lower and then goes higher. So 7th and the 8th nerves must be identified laterally in the canal, medially at the brainstem, and from both the sides you converge to the most adherent point just outside the porus acousticus. So you identify the nerve either laterally first or medially first, but don't go away. From both these points, you come just outside the porus, and that's the point where there is a maximum adhesion of the tumor to the facial nerve. That is a technique. So I will show you Now the internal auditory canal is opened. The canal is lying like this. The canal is open. I'm delivering the tumor from the canal. After drilling the canal open, you deliver the tumor. You bring it out. And you come right towards, just outside the porus acousticus. And as you come out, you'll find that the tumor is adherent over there. And when you find the adhesion, you stop over there. Otherwise, you will tear the facial nerve in that point. So stop over there. We have analyzed the degree of displacement and the direction of displacement of the facial nerve by the acoustic tumor, and you see that there is no standard direction in which the facial nerve can be displaced. In the majority of patients, it is displaced like this, but it can be upwards and it can be backwards, it can be downwards, but it's always ventral to the tumor, never on the surface of the tumor. But still, we always stimulate the surface of the tumor just in case you have the odd chance of a facial nerve appearing at the beginning by the rotation of the tumor or whatever. So always use a stimulator and then you follow the facial nerve. The section of the seventh nerve is very important. It can be so thin that it may sometimes not be visible as a nerve. It will only be visible like an arachnoid. Thin, very thin. So wherever you stimulate, it will stimulate. Wherever you touch the arachnoid, it will stimulate. Because the whole nerve is spread out like a sheet. It's not thin like a straight line, but spread out like a sheet. So you use the electrostimulator and electrophysiology to identify the nerve, and then gently separate it by using microdissection and sharp arachnoid dissection. A small part of the tumor may be left behind to the seventh nerve, because if you force it, you may damage the nerve. Facial paralysis can be temporary or can be permanent. In spite of being anatomically in continuity, you can have a facial nerve damage. And this can occur because of neuropraxia. It can occur because of interruption of blood supply by coagulation of the auditory or the labyrinthine artery. It can be nuclear lesion by traction. It can be thermal injury when you are drilling. If the assistant is not irrigating the bone, it can cause thermal injury to the facial nerve. I have sometimes seen in my practice overstimulation. Go on checking all the time. There can be a transient paresis. And sometimes our ambition, over-ambition, to dissect the last and the most adherent part of the tumor. I'll show you one example of this very large tumor. This was a young Indian girl. She was a model and she was a dancer. And she had such a big tumor. Till that time, she did not know that she was having a tumor. Only after this size of tumor, she started to lose balance. Till that time, she was dancing normal. And see the size of the tumor. This is the post-operative appearance, but I'll show you. This is the girl. After surgery, she still has a small facial weakness. But the size of the tumor was so big. And a small bit of tumor capsule is left over there. But she has no ataxia and she's reasonably happy. But such is the size of tumor you can get before you can get symptoms. You can imagine. Finally, lower cranial nerves. The patient will not die if you damage the facial nerve. The patient will not die if you damage the hearing nerve. But patient can die if you damage the lower cranial nerves. Do not handle the lower cranial nerves. Do not see them. Do not touch them. Do not put cotton between the tumor and the nerve. You will overstretch it. So, you must first debulk the tumor, make it small, make the big tumor small. These are the lower cranial nerves. After you make the tumor small, you can lift it off. And then you can put some cotton. You can see how stretched the lower cranial nerves are, how badly stretched they are. And if you try to put cotton inside, it will get more stretched, more damaged. The challenges are of three types. Complete removal is a challenge, cystic tumor is a challenge, and tumor growing in spite of radiosurgery. how much surgery should be done, how much removal should be done. Prolonged surgery can be very dangerous in the elderly people and sick patients. And you may have to go in stages, or you may have to stop. You may have to just do debulking. Do not insist on removing the tumor completely in very old people. Cystic tumors is another challenge. It looks very easy on the scan that you will remove the cyst and the tumor will just come out. Cystic tumors are more dangerous than solid tumors. They have more adhesion with the cranial nerves. And they require very careful dissection with the surrounding structures. Look at this small cystic tumor that you can see over here. Cystic cum solid tumor. And I'll show you the video of this patient. Oh, what happened? So that is the tumor. It's a cyst. We open the cyst, empty the tumor from inside. But that is only the easy part of the operation. Now carefully, you must go all around the tumor, very carefully, see the capsule of the tumor, see the adhesions with the 7th and the 8th nerve. Now you can see how densely adherent it is. You have to be very gentle, very careful. And now you can see the separation. You can see the 7th nerve, the 8th nerve, and the ICA. And the patient next day after surgery. Okay, that is done. That's another case. You can see the size of the solid tumor and see the size of the cyst. Very huge tumor. Dangerous. I call them dangerous tumors. Cysts can be easy to evacuate, but the adhesion to the nerves is very dense. And this patient had a hydrocephalus because of this large size. And see this tumor. Large tumor, cystic tumor with hydrocephalus. And this is after surgery. And the last part of this talk is failure of radiosurgery. Very important to know, today it has become fashionable for surgeons to remove the tumor partially, just empty something and send the patient for radiosurgery. They don't want to make their effort, they don't want to challenge themselves by removing the tumor completely. They just remove it partially. They say it is not important because there is radiosurgery, otherwise I damage the facial nerve. So they remove the tumor. Now this man saw me with loss of hearing, imbalance, tinnitus, numbness of face. This was January 2010 when he saw me first. And then he went on his own for CyberKnife. After CyberKnife, his tumor became more adherent, more dense, become necrotic in about 3 months' time. But his symptoms continued to progress. He was more symptomatic than before. So finally, he was so troubled by the trigeminal symptoms that he came to me for surgery. Now you can see how difficult it is to operate on this tumor. Sorry, this video quality is not so great. It's very adherent tumor, very tough, very leathery, very difficult to separate from the facial nerve. But you have to do it. So I'm using, and finally we get to the facial nerve. We are separating the tumor, cutting it. You can see the facial nerve very well, but not very easy. Now the facial nerve is preserved anatomically. Tumor is completely removed. But see him. Oh, sorry, the post-operative I should show you. Immediate post-operative. You see, he has got a dense facial weakness, very bad facial weakness. In spite of anatomic preservation, you can see his facial weakness. This is the problem with radiosurgery. Fortunately, after some months, he recovered, and he is giving a talk in my office. He's telling the people, never go for radiosurgery. He wants to say, oh, I don't want to take you through that dialogue, but he was complaining about severe trigeminal dysesthesia following radiosurgery. Mortality, now I have done about 1,980 cases, about 1,000 cases, and mortality rate is still 0%. I have not lost even one acoustic tumor after 1985. Complications are there. Mortality is 0. Complications are there. Permanent facial palsy is there. Bronchopneumonia is there, especially in the old people. Sometimes spontaneous infarct. So there is no surgery without complications. But why they occur, you have to learn. They are dependent on the nature of the tumor and the operative difficulties. Especially operative difficulties are sinus complications, poor arachnoid plane, venous occlusion, vessel injury, perforator injury, cerebellar swelling. This operation is a very dangerous and difficult operation. Acoustic neuroma surgery is to be done by people who are regularly operating on these tumors. Should not be done by somebody who does 1 or 2 acoustics in a year. You will not get these results. Please be careful. At the end of an operation, the trophy is not the tumor, but the viable patient. That is what Al-Mufti says. And I would say with a good quality of life. And the quality of life is determined by his ability to swallow, ability to articulate, to walk steady, no ataxia, and not to see double. This is quality of life. So conclusion is that patients harboring large or giant vestibular schwannomas score lower on all the quality of life compared to the normal population. These are my results. I don't know whether we have time for this, but the point is that many times patients will develop less than 3 centimeters. We have about very good results, but more than 3 centimeters, you can see the results are going down. So we have anatomical preservation of 91% of 7th nerve and about 43% of 8th nerve. Surgery for giant vestibular schwannoma is delicate and complex and hence must be done only by experienced neurosurgeon. Microsurgical total excision is still a gold standard treatment, particularly for giant tumors. Radiosurgery, though increasingly used for small tumors, may be useful for subtotally remote giant tumors, or if the residual tumor shows increase in growth. And when you are following your patients up, contrast MRI is the investigation of choice. You must not do any other scan but a contrast MRI to follow the tumor, the residual tumor and the recurrence. I must say that everybody is today talking about preserving the facial nerve, preserving the hearing, but I'm again saying that please remember the goal of acoustic surgery is to save the patient's life and to preserve the quality of life. The quality of life which allows him to swallow, to articulate, to walk steadily, and not to see double. Preservation of 7th and 8th nerves, though ideal, is not always achievable. Thank you very much for listening to me.
Okay, thank you, Professor. Very interesting presentation. Вопросы? Ну, в общем-то, ретросигмовидный доступ, я думаю, используете, да? Достаточно часто. Кто использует? Кто-то может? Да. Вопросы к профессору? Подумайте, наверняка есть какие-то. По работе что-то вот у вас, может быть, какие-то конкретные нюансы. Хотелось бы узнать.
Thank you, Professor Turo. Perfect presentation, perfect preparation today. Thank you. My questions. We use neurotization of facial nerve. Neurotization. We use. If you see that facial nerve damage, And you use if, nevropatization.
Yes, of course. If you have a visible damage,
Yes.
if
Yes.
you have both the stumps visible,
Yes.
the proximal stump and the distal stump both are seen, you can bring them together directly by one stitch or by fibrin glue. You can put it together, it will work. But quite often you may not be lucky enough to see both.
Yes.
And if you do not have a proximal stump, you can do nothing about it. If the proximal stump is not there, you cannot do neurotization at that time. But if you have a proximal stump visible at that time, you can take a small sural nerve, suture it to the proximal stump, and bring it out through the mastoidectomy and suture it to the facial nerve at the same time, at the same setting. These cases are not very common. And usually you do not see the facial nerve at both the ends. I mean, there's a big gap, or you don't see anything. Then you have to do a facio-hypoglossal or facio-facial or any other. There are many other ways of neurotization.
Thank you. Thank you, Professor.
You were there today for the operation, Yuri. So, yeah, so you see, we follow the same steps exactly. We made the operation in the morning today on acoustic tumor. It's exactly the same steps that we spoke just now. It is not from the theory, you have seen the operation practically. None?
Okay,
Thank you very much.
Thank
Thank
you.
you. Thank you.
Следующая лекция будет профессор из Бразилии по опухолям третьего желудочка Марчелло Феррейра. Correct?
Professor Sufyanov and Dr. Barber to be here in Tumen. It's a wonderful people and a marvelous Institute of Neurosurgery. I will talk about microsurgical approach to the tumor of the third ventricle. We have new techniques, of course, endoscopic techniques, but sometimes when you have a small ventricle, you are unable to do the endoscopic procedure. For this reason, we need to use the old technique of microsurgical approaches. Well, something wrong. It's not running, maybe, I don't know. Let me see. The computer is not working. It'll take a few minutes. Well, Microsoft's good. You can take several minutes. It works, takes time. Okay, let's go start again. That's what we call lazy computer. Nobody will forget this presentation. Well, now it's ready. The first description that we have about the third ventricle was a draw by Leonardo da Vinci that he injected wax inside a cow's brain, and he described the third ventricle. Vesalius did a lot of beautiful draws of the anatomy of the ventricles and the brain, and you can see enlargement of the lateral ventricles and the third ventricle in this draw. But the first neurosurgeon to describe the surgery of the third ventricle was Walter Dandy. We have many structures surrounding this cavity in the middle of the brain. You have the optic recess, infundibular recess, it's important, midbrain, hypothalamus, pineal recess, suprapineal recess, thalamus, massas intermedium, corpum caloso, septo pellucido, and fornix, of course, foramen of Monro. Very challenging area. As you can see in this draw, in this anatomical preparation, you have many vascular structure in the floor of the third ventricle, the anterior cerebral artery in the anterior portion, the optic nerve, and the hypophyse in the anterior part of the third ventricle. It's important to know that the choroidal artery in some tumors are necessary to coagulate to avoid bleeding, and you have the pineal region too. Some of the tumors of the third ventricle comes from this area. As you can see, the venous drainage is very important, especially thalamus straight vein and superior choroidal vein to reach the third ventricle, and basal vein of Rosenthal as the vein of Galen. The epidemiology of the tumors of the third ventricle. The anterior part, basically we have colloid cysts, astrocytomas, germinomas, metastatic disease, craniopharyngiomas, meningiomas, ependymomas, choroid plexus papillomas, AVMs, and basilar aneurysms. In the posterior part of the third ventricle, tumors of the pineal region, like germinomas, and they are about 50% of all tumors of the pineal region, epidermoid tumors, meningioma, and astrocytomas. Third ventricular tumors represents about 1% of all the brain tumors. And the clinical presentation is increase in ICP. The tumors works like a cork, and you have an obstruction of CSF flow, dysfunction of the lung tracts, visual disturbance, oculomotor disturbance, endocrinological dysfunctions in the anterior part of the third ventricle, and hypothalamic dysfunctions. The investigation before the surgery, you must have the endocrinological and biological investigation. If you have a germinoma, visual field, skull X-ray and sella turcica, it's important to see the enlargement, CAT scan with all cuts, especially the coronal cuts, brain MRI, radiological study of deep and the superficial veins to plan the approach, and angiography by any method as MRI, angio-CT, or catheterism. It's important, as we see in this draw, the great vein of Trollard, when you use a transcallosal interhemispheric approach, the deepens both internal cerebral veins, it's important, and thalamus straight veins to avoid venous infarct. The approach, basically, we divide in the body of the third ventricle and the third ventricle itself. In the body, you can do anterior interhemispheric and transcallosal approach. To the third ventricle, we can use a transchoroidal approach, interfornicial, subfrontal, a velo-interposital, we call infratentorial supracerebellar approach, described by Krauss, and in 1974, Stein started to use this technique and use this technique until nowadays. Transsylvian and transsphenoidal approach. As you can see, we can use combined approach, interhemispheric approach, transcortical approach, and we can use combined anterior interhemispheric and subfrontal approach to reach the third ventricle. Transsphenoidal approach, you can do this by with using of a speculum, the traditional technique, or nowadays endoscopic technique. Here you can see enlargement of the sella turcica, and enhancement ring in this tumor was a craniopharyngioma going to the third ventricle. The opening of the floor of the sella turcica, removal of the capsule of the craniopharyngioma, and you can see in this photo with the aspirator, you can see the third ventricle in the dip of the photo, and the CAT scan after the surgery with the air in the place of the tumor. In the anterior part, we can use terminal approach and subfrontal or transsylvian. And the approach with this kind of craniotomies are optocarotidic space or cistern, prechiasmatic cistern, and translaminar terminalis approach. As you can see here, you can reach the third ventricle by all of these approaches. Here you can use the subfrontal and or transsylvian, and you can see the optic nerve, the carotid artery, and here is the drawing on the right. You can see the removal of the tumor by prechiasmatic approach, and you must, before the surgery, know if the chiasma is prefixed or not. And as you can see here, the removal between the carotid artery and the optic nerve, and complete removal of this lesion in the MRI in the bottom. This is another tumor, solid tumor, and you can see the optic nerve, the chiasma enlarged, and you can see from any other route the tumor, the opening of lamina terminalis. You can see the tumor in the appearing by the lamina terminalis. And this is another tumor that you can see before and after. You can see the pituitary stalk on the bottom after a complete removal of this another tumor of the third ventricle anterior part. Transfrontal approach is a transcortical approach, and you can easily reach the third ventricle by identifying the foramen of Monro. As you can see, you do a little corticotomy, a square craniotomy, and you see this supposed tumor, but it's not a tumor in the foramen of Monro. This is a cysticercosis. The posterior part of the third ventricle, you can use the anterior transcallosal approach. You see from the front to the bottom of the third ventricle. And you can use the transforaminal approach, interfornitional, and subchoroidal. As you can see, you get between the two brain hemispheres, do a craniotomy crossing 1 centimeter from the midline, seeing the sagittal sinus. You must be very careful with the veins to avoid infarct of the brain, venous stasis. And you reach the third ventricle, splitting the both callosal-marginal arteries. As you can see here, the position, we do a large craniotomy, not usually, sometimes a little smaller, the splitting of the two arteries, the opening of the corpus callosum. Corpus callosum is more white than the singular gyrus, you identify the foramen of Monro, and then you reach the third ventricle by foramen of Monro. Here you can see the colloid cyst of third ventricle, and you can see the choroid plexus, the Monro foramen, and the colloid cyst inside the third ventricle. Removing the colloid cyst of the third ventricle, you must remove the capsule to avoid regrowth of this kind of cysts, colloid cyst of the third ventricle, and you can see the floor of third ventricle after a complete removal. This is another large cystic lesion, and this was a cysticercosis too. A little unusual because it was a larger lesion, but was cysticercosis again. And you can see the removal of all the cysts, and you can see in the third slide on the right, the opening of tuber cinereum and visualization of the posterior fossa. Transcallosal approach interfornicial, you can do in very large lesions. You have the risk of compromising the memory of the patient, but it sometimes is the only way to remove large lesions like this from the third ventricle. And you can see the removal of capsule, and you can see the third ventricle. In a CAT scan after surgery, you usually put a drain to avoid any bleeding inside, and the patient can develop acute hydrocephalus. Subchoroidal approach can give you a larger root when you don't have, as in larger and solid lesions. And you can see the choroidal fissure, the splitting of thalamus striate vein, and removal of the tumor. The posterior part of third ventricle, you can do two kinds of approach. Supratentorial approach, interhemispheric, suboccipital approach, supracerebellar. If you are supratentorial interhemispheric, you must be very careful with the both two deep internal cerebral veins. You can see the tentorium and the faults. Sometimes the tumor is beyond the veins, after the veins, and you must be very careful not to avoid lesion of this vascular structure. You can see here an astrocytoma. You can see the faults, the dissection of the lesion, and you can see in the right slide, the right picture, the third ventricle, and after a complete removal of the lesion, the foramen of Monro, and CAT scan after the surgery with a drain. Paraventricular astrocytomas and cavernomas, you can use the same route, and you can see here, identifying the tumor, removal of the tumor, and a CAT scan after a complete removal of this lesion. Infratentorial supracerebellar approach, it's an elegant but sometimes a little tricky approach. You need to open the velum interpositum, and that's why I call velum interpositum approach. The position of the patient is important. Sometimes this position, the patient can have air embolism, and the position of the head is very important because the tentorium must be horizontal because it's important for visualization of the surgeon, of the tumor. And then you can reach the tumor with very, very long surgical instruments. Here you can see a tumor. This was a pinealoma, the approach, supracerebellar infratentorial approach, velum interpositum. As you can see, the tumor. And after a complete removal, you can see the roof of the third ventricle with choroid plexus. This is another case, patient with hydrocephalus. It was an older patient, and this was a glioblastoma of the pineal region. was completely removed, as you can see, the lesion. You can see in the left the lesion, and in the right, the both internal cerebral veins, and after complete removal, the choroid plexus of the roof of the third ventricle. And this is 6 months after surgery, the regrowth of this glioblastoma without hydrocephalus, but a regrowing of the tumor. This is another case with calcification near the pineal region. The diagnosis of this was cysticercosis again. It's not endemic in Brazil. They're quite rare. Conclusion, the selection of the suitable approach is very important. Vascular knowledge, arterial and venous. Neurophysiological and neuroendocrinological knowledge is important, and restoration of CSF and removal of the complete tumor, it's the goal. And I want to invite all my fellow neurosurgeons and Russian friends to the Brazilian Congress of Neurosurgery that will be in 2018 in Porto Alegre. Thank you very much.
Okay. Thank you, Professor. Вопросы? Questions? Okay. Okay. Thank you. Так, следующая лекция будет от профессора с Таиланда. Утипонг Тиракатай. Будет посвящена она тоже шваномам. То есть будет две презентации. Первая презентация непосредственно та, что заявлена по хирургическому лечению шваном, а вторая по как раз реабилитации повреждения фасциального нерва. Вот у профессора очень большой опыт именно командного подхода к этой проблеме. То есть работа нейрохирургов, пластических хирургов.
Okay.
Thank you.
Dear colleagues, thank you very much for giving me the chance to share with you my trigeminal schwannoma experience. This is the concept that I learned from both of my boss, Professor Batalanfi and Professor Anusak Liangudong, which is my senior surgeon in Thailand. This is the place I come from. You know already, this is a panoramic view of the Bangkok. And this is our Grand Palace. And let me introduce you. This is my hospital 55 years ago. This is the first dedicated hospital to the neurosurgical department in Thailand. And this is the picture now today. We have like 1,600 cases, major cases a year. We have the training program, and we are looking forward to the collaboration, international collaboration. My neurosurgical journey began in 2007 after returning from Germany. This is the skull-based course, the first one that I organized in 2011 together with Professor Henry Schroeder and Professor Charlie Thiel. And the second one in 2013 together with the French neurosurgeon and ENT and Professor Samishima. And 2015 with Professor Albert Sofino, Professor Luis Boba. And this is our new building. We will have the surgical laboratory training center on the third floor. We have like 16 stations, and we are looking forward to some of you here to visit our place. This is just recently we have the course in July, and Professor Luis Boba is there. This is the talk that I will share with you about the epidemiology, pathology, and classification, clinical finding, diagnostic evaluation, surgery, and its consideration and role of radiosurgery. As we know that the trigeminal schwannoma is the benign tumor, is the WHO classification grade 1, and usually light from the oligodendroglium at the Schwann cell junction. And the most trigeminal schwannoma are sporadic tumor. Some are associated to the NF2. It's quite rare, and the incidence just only is 0.7 or and 0.3% of all brain tumor. It is the second most tumor of intracranial schwannoma, commonly in female, and the peak incidence is between 4th and 5th decade. We know already that the pathology have the Anthony type A and B. The clinical presentation usually come with the facial hypoesthesia. Some may come with facial pain and or trigeminal motor dysfunction. And other cranial nerve deficits are quite rare. According to Jefferson classification, Jefferson divided this tumor into 3 types. The one is the middle fossa. Second type is posterior fossa, and the third type is dumbbell shape. And Sami add more classification. He had like a tumor predominantly extracranially. This is additional type. And recently, Fukushima just and his fellow just published the new finding, and they just rearranged at some type of the cavernous-related tumor in this region. Let me share with you with the meningeal architecture of the cavernous sinus area. This is from a paper of Professor Kalbase. I would say that this is, we know already today that the cavernous sinus divided into two parts. One is the dura propria, and the other is the ostial layer. And for me, I would say that we can have the consideration that whether the tumor involve the anterior cavernous sinus, or involve the posterior cavernous sinus, or at the Meckel cave, or the tumor at the posterior fossa, or extracranial extension. This is what I will look at the tumor when I decide for the operation. I will show some of my surgical case. This is the tumor that the patient's 54 years old female come with a headache and the visual decrease. And we think that the tumor is at the anterior cavernous sinus, and we have to decompress the nerve. So this is the pictures that I plan our aim that we will go extracranially to the optic nerve, and we should see the tumor there, and we should decompress the nerve. And this is the surgical video. We use the terminal craniotomy. We go directly to the lesion, and this is the optic nerve. We do the drilling. To decompress the optic nerve. And then we saw already here that the tumor. The tumor is extradurally. And I think that we can incise the dura propria. And in a minute, in a few seconds, you will see the third nerve. I incise it, and this is the third nerve. You see the third nerve here? And the tumor is there. We cut the dura propria, and we start to take the tumor. Yeah. We take the tumor, and we understand it, that this is just the lateral wall of the cavernous sinus. The tumor not enter into the cavernous sinus, but if we bleach into the deeper layer, this is the fourth nerve. We see the fourth nerve already. And if we go deeper, It will be the bleeding from the cavernous sinus. And you see it in a second. And this is coming, the venous blood that now we enter into the cavernous sinus, and we can control by using the gel foam to plug in. And then I will go further a bit and to see this is the carotid artery. And this is our surgery. And we go without go into the intradural space. And this is this is the possibility of MRI. The patient have to improve visual acuity from 20/200 to 20/25, and we still keep watching the tumor without sending to the radial surgery. The second one is posterior cavernous sinus, and this tumor we have analyzed it, and we saw that some part extend into the intracranial, and this is just this is the 67 years old female. So our decision is to go intracranially. So we use the terminal craniotomy. We go intracranial, intradural, and we open the arachnoid. Now you see that this is the carotid artery. This is the third nerve, and this is the optic nerve. This is the tumor. You already know that this is the tumor. The tumor is in this area, and we try to dissect the tumor away from the third nerve. The working channel is through the optic nerve and carotid, and also and also the working channel also through the third nerve and up the carotid artery. We do the dissection to deliver the tumor slowly, and this is the third nerve. And you see here, this is the petrochiral fold. This is exactly in this area beneath the third nerve. And slowly, gently took the tumor out. And you will see there are still some tumor remnants connected to the posterior part of the cavernous sinus, which you will see in a few seconds. And now this is the area that we think that is the cavernous sinus region. This is the third nerve here. So we deliver some part of the tumor that behind this petrochiral fold, petrohenoid fold. Okay, and then this is the tumor, the last one that we take it out. And see again, this is carotid artery, optic nerve, third nerve. This is the post-operative pictures after 4 years. We still keep watching this patient. Come to another classification of type of the tumor. This is the tumor involved the Meckel cave and posterior fossa. This is the pictures of a female patient. She's 23 years old and have a facial numbness. And my approach is to the middle fossa approach. We do the dissection as we learned today. We already performed the dissection, and this is we see already this is the carotid artery, and then we cut the foramen spinosum, middle meningeal artery. We expand the foramen over a little bit so as we can mobilize the fifth nerve. And this is what today Professor Kimura already showed you how to perform the anterior petrosectomy. And we just drill the to do the anterior pituitary, just a premeatal approach. We do it until we see the posterior fossa dura, and we start to remove the tumor. This is the area we already see today. We do the pituitary here, and we start to deliver the tumor that located beneath the fifth nerve. And this is, as I told some of our participants, that we can manage the bleeding from the superior pituitary sinus through with using the gel foam. And then I start to take the tumor from middle cranial fossa from the medial cave, and then this is at the posterior fossa region. And we will see the fifth nerve in a few seconds. And this is the fifth nerve that we can see. And we try to gently remove the tumor both from the posterior fossa through the medial cave until beneath the fifth nerve. And this is the fifth nerve, and this is 7 and 8. Exactly in this area. And these postoperative pictures of the patients. The next one is the posterior fossa type of the tumor. This is 61 years old female, come with a decreased hearing and headache. So the decision for me is to use the retrosigmoid approach, as we already learned today. After opening the dura, and we go directly to see the tumor, and this is the 7 and 8. And then we start to incise the tumor just beneath the facial nerve, and then we gently remove the tumor. And finally, after gradually remove the tumor, you will see this is the cystic part of the tumor that we see already from the imaging. And then we, after debulking the tumor, we start to dissect the tumor capsule away from the nerve. And this is maybe the feeder of the tumor. And you will see in a second of the sixth nerve here. We can preserve the this is 7 and 8. And then we will see 6, and this is 6, no? And this is 5, okay. And the tumor are completely removed. For the extracranial extension, I would say that there is a role of the endoscopic and the nasal resection. The skull-based surgeon should have at least another armamentarium to take this part of the tumor. And the indication for the trigeminal tumor should be the tumor that involve V2 or V3. And this is my case that I at the beginning, I'm thinking about the approach that I want to use. And then finally, I use the endoscopic approach, using the transsilicoid approach to take the tumor. And this is not the endoscopic cause, it's just the microscopic cause, but we can go to the infratemporal region using the endoscopic surgery. And this is the postoperative picture using this approach. And this is the patients after 1 week of postoperation. Another thing is that we have to think that radiosurgery also have a role. Although I agree that we should try our best to remove the tumor, but we cannot say that radiosurgery is not useful. Sometimes we have to consider using it, especially in the high-risk patients. Old age have the medical condition that it's not want to operate. And there are some paper report that they have a good control rate of the tumor. And come to the conclusion, I would say that there is no single operation suitable for all trigeminal schwannoma. Surgeon should tailor his or her own surgical approach or approaches according to the location of the lesion and strategy, as well as surgical experience. Thank you for your kind attention. Me?
Окей, thank you. Ваши вопросы?
Any questions?
Ну, давайте поактивнее. Вы устали?
I have a question.
Please.
Yesterday, Dr. Barber did a surgery of trigeminal schwannoma. Sami published some years ago something like 40-something cases to the approach of the tumors of trigeminal schwannomas. The question is, you have the growth of the tumor sometimes more in Meckel's cave
Yes.
and middle fossa, sometimes more in the posterior fossa. To avoid difficult problems during the surgical approach, which is the best approach that you suggest to approach these tumors? Because they are challenging,
Yes.
they're rare, and sometimes difficult to resect them.
I think the answer is that if you master in any kind of approach, you should do it. For example, Sami is the master of retrosigmoid approach. He can go through the anterior cranial fossa to the retrosigmoid. If you have the capability to perform this removal of tumor, although the tumor have the extension into the middle cranial fossa, if you can do it, and the patient have a good result, you can do it. But if you are just the starter, I would say that if the tumor is very big, sometimes you have to say that you use two-stages approach. You go to the retrosigmoid once, you still have the tumor in the middle fossa, and you do it again through the middle cranial fossa. This is my idea. Maybe, Roy, you want to say something? Yes.
I think what is mentioned in your presentation is the answer, that there is no single approach. I think we should get trained in all the approaches. And my feeling is that the best approach is the transtumoral approach.
Transtumor approach.
Yes, so if you can get the tumor to be as superficial as possible based on any skull-based technique, then what you're actually doing is approaching it through the tumor. So get the approach that is closest and get closest to you. So a transtumoral approach is probably the answer to a question that encompasses the whole different types of the lesion.
Oh, I agree. Yeah, thank you.
Okay.
Good. Okay. So my next talk will be the multidisciplinary approach to surgical reconstruction of the facial nerve paralysis. This is what? Okay, this is my another topic. This is something that I learned after I came back. This is our this year course in July and in August. The problem is that when I came back from Germany, in the European country, the tumor is very small. But when I return to my country, the patients always come with a big tumor. And for example, like these patients, NF2, you already know, and then they have the 2 tumors and come to the hospital in the bedridden condition. What do I have to do? So I have to decide to remove the tumor one after the other. The first one, left tumor, and the second one, the right tumor. This is the post-operative MRI. But the patient still have some facial paralysis. And this is her selfie picture taken and sent to me. And for me, is that how can I improve the quality of life of these patients? Because Kiki said that quality of life is so important. So I have to improve the quality of life. We know already that the facial muscle is very important. And if any paralysis happen to this group of muscle, you will not be able to smile, which is very important for Thailand, because Thailand is the land of smile. People will love to smile. They cannot smile, they will be very sad. And then you will have the problem of oral incontinence. You have the ocular dryness, and sometimes you also have the nasal airway obstruction. And the most important is that emotional distress. They cannot enter into the society. And this is the devastating condition, and especially the psychological consequence afterward. And the cause may be for many reasons: neoplasm, tumor, infection, idiopathic cause after Bell palsy. So my team is a facial clinic team. Together, we start 4 years ago. We have like neurosurgeon, ophthalmologist, PM&R doctor, psychiatrists, and neurosurgeons. We work together to focus on how to restore the form and the function of the individual patients. And we will examine the facial nerve activity, pre-operative and post-operative. This is the team. Instead of coming to see one doctor after the other, the doctor sitting together and discuss the problem of the patients. The goal is that how can we bring back the facial symmetry at least, and how can we create the dynamic smile, and how can we improve how can we solve the problem of the dryness of the eye. And this is preoperative and postoperative pictures after the facial reanimation. Consider to the operative technique, the static correction, which is be done by the plastic surgeon, and also the dynamic reanimation using the nerve. Again, no single operation applicable to all cases of facial paralysis. The team will work by divided the face to upper, mid face, and lower face. The upper face, we try to protect the eye. The mid face and lower face, we try to have the voluntary movement of smile and facial symmetry. Go to the upper face with the eye protection. We do the lateral tarsography. We can use the Go-Away implantation. This is the work of the ophthalmologist. And recently, just for 1.5 years, we start to do the corneal neurotization. This is something unusual. We will use the contralateral, supraorbital, or supratrochlear nerve. We will mobilize the nerve from contralateral side, and to put it around the limbus. You will see the video. We hope that we can restore the corneal sensibility, and we hope that there will more nutrient to the cornea, and to solve the problem of corneal scar. This is the pictures of patients from other hospital sent to our hospital to ask for the facial reanimation. So as you see that the patients have the problem of the corneal scar here, and so we do the corneal neurotization. Neurosurgeon open, and together with the plastic surgeon, we together try to harvest the nerve for the ophthalmologist. And that afterward, the ophthalmologist will put the nerve around the cornea. then we can divide the nerve into more branches, and we put the nerve around the cornea. And then we do the suture. You see the nerve is now around the cornea. And we do the sutures of the conjunctiva. And it is the postoperative pictures. And we found that nowadays the corneal scar is thinner. The patients can look through this scar, and she said that her vision is improved. And for the mid-face and lower face surgery, we will try to make it to create the smile branch. As we know already that the branch that is responsible for the smile is there are many variations. So we try to find the zygomaticus major branch that supplied this muscle. We also use the intraoperative monitoring to find this nerve. So as that we can anastomose directly to the branch that we want to have. There are several techniques we use. Some mesothelic nerve to the motor unit, mesothelic nerve to free flap, cross-facial nerve gap to the muscle unit, cross-facial nerve gap to free flap. Depending, for example, if these patients still have the good motor unit, you don't need a motor unit. You just need the new nerve. So the nerve that we use is mesothelic nerve. This is the postoperative pictures. Yeah. And this is pre-op and postoperative pictures. And this is the second patient, vestibular schwannoma with a facial palsy. We use the same because she's old age. We want to have the fast. And these patients, you don't have to ask her to bite the teeth. She can smile directly. When she thinks she wants to smile, she can smile. This is very interesting because there are reports about the cerebral plasticity that happen when you want to smile. There may be some connection between the nerve that make you smile without your biting your teeth. And if the motor unit is bad, you cannot use the motor unit because the muscle unit is already atrophy. You use the gracilis free flap. This will be done by the plastic surgeon. He will have the motor unit for you, and you use this is not that good because the patient already have the trophy, but at least they can bring back some smile. This is also another one that we use the transfer gracilis muscle free flap, and this is another one. I would say that if we can do the reanimation, the earlier we can do, the better result we have, especially before the muscle atrophy occur. Another technique that we can apply to this is the cross-facial nerve gap. In case that you want to create the dynamic smile, that you smile, when you want to smile, the other side smile, this side also smile, you can jump using the cross-facial nerve gap. I would prefer to use the endoscopic because I think it's a less trauma to the nerve. So I use the endoscopic to harvest, and the endoscopic technique, I use the endoscope to harvest the sural nerve from the thigh, and to take as long as you need. After that, you can deliver it from proximal to distal. And you can measure how long you want. And then we add also another nerve like babysitter to prevent the muscle atrophy after you use the cross-facial nerve gap. Some may report that they use the mini hypoglossal branch, but we would recommend to use the mesothelic nerve. This is the patients that have the problem of brainstem hemorrhage with facial palsy. So we use the cross-facial nerve gap with babysitter. And this is the one that we use, hypoglossal for babysitter. Yeah, we can create the dynamic smile of these patients. The other reconstruction may be the causafacial nerve gap using the free flap. If you don't have the good motor unit, again, you use the free flap. This is the petrochival tumor. After remove the tumor, the patients have facial palsy. And this is pre-op and post-operative after the reanimation. So come to some conclusion that there is no chance to restore the patients to the normal facial function, and the permanent deficit are still in the voluntary control. So another treatment that is very necessary is try to support the patients because they are really sad that they cannot go to have the social activity as before. So we have like 64 cases that we work together, and some are upper face alone, some together upper and mid face and low face. This is solo causes of our surgery, most from vestibular schwannoma, and some from Bell palsy, and some from petrochival tumor. And there are several types that we use now. We use mesenteric nerve. Sometimes we use the causafacial nerve gap. And I think that all techniques of the surgery have improved the outcome. However, the technique has variable duration of improvement. And the technique of the causafacial nerve gap with the babysitter has the best outcome on the period of recovery. And according to our work, in 2015, we got the National Services Award from the government. Thank you for your kind attention.
Thank you, Professor. It's a very nice presentation. Good facial nerve reconstruction. Вопросы? Yes, do you have?
I love to ask questions. No, they have some technique of split the hypoglossal nerve to avoid the tongue atrophy. And this is, I think that's a Brazilian technique that they developed. Have you ever tried this technique to split the hypoglossal nerve, take part of it to do a hypoglossal facial anastomosis and keep the rest of the nerve in innervation with the tongue?
The problem of the reanimation using hypoglossal technique, the nerve gap is not that long, one thing. The second is that when you anastomose to the stump or to the trunk, you face the problem of synkinesis. For example, you close the eye, you smile. When you smile, you close the eye. You cannot control it separately. So our strategy is to separate, to connect, to anastomose to the specific branch that we want. This is the answer. Thank you.
Okay, and I ask.
Yeah.
How many times from operation? I'll say. From when
should we use the facial reanimation? First, we have to be sure whether we injure the facial nerve or not. If we think that the facial nerve anatomy is preserved, nothing, we save everything, but the patients still have, we wait until we do the NCV EMG to check whether the waveform, the activity is gradually improved or not. But if we think that there is no electrical activity, some kind of regeneration does not occur within 6-7 months, I would recommend to perform the surgery. But if you are sure that you lost the 7, I would say that try to do it as early as possible, except you suture in intraoperative. But if you don't do anything, you cut it, you should do it as soon as possible. Otherwise, the muscle will be atrophy.
Okay.
Yeah.
About the limit after 1 year, 2 years, 4 years?
The limit, I would say, before 1.5 years, not longer than 2 years. Yes.
Okay. And what kind of endoscope use taking graft?
I use the START scope.
START. Okay.
Yes. Yeah. We can use it. Yeah.
Thank you.
I never used to anastomosis directly to the trunk. Yes, I will find the branch. We will see the patients how they smile, the type of the smile that they have. Some patients we use the cytosolius. Some people use the zygomaticus major. This is the detail that we will discuss with the plastic surgeon, and he will think that which branch should we anastomose. So together we enter into the operating theater. We discuss about that. We stim the nerve and to see the reaction and which branch should we anastomose. And we decided again when we found that. First, we have in mind which branch we are going to anastomose, and we go to the operating theater, make a stimulation, and see the reaction of the muscle contraction. And if we see it, we decide to anastomose to the specific branch to get the better outcome, to make sure that the patient will be able to smile after we reanimate. Yes. Yes, from the contralateral side, because sometimes you don't know exactly what happened. Because when you perform the retrosigmoid from petrochial, vestibular, big one, you may damage some nerve here, fifth nerve or something. So this is the reason that sometimes yes, because sometimes the patient also have the problem. The fifth is sometimes preserved. Video over? Corneal neurotization? Yes. Yeah, I put the corneal neurotization, that one. I do the bicoronal incision, go to until we come into the orbit here. We identify the nerve, we take the nerve, and then we harvest the nerve, long one. And then we insert to the under the skin until we put it in here. Above the below the upper the orbit, but under the conjunctiva, and then we slide the cornea. We believe that the limbus, yes, but under, yes, but under, huh? We don't know exactly whether it's going to regenerate. We performed 3 patients using this technique. We observed and we found that the scar is thinner. And we test the sensation. It seemed like there's some improve of sensation, but patients still have the problem. They cannot blink. But at least you put the natural eye tear less frequent than before the surgery. Before the surgery, they have the problem of dry eye, redness, the scar, and all these things. But after the surgery, the patients still have to use the natural tear, but they less frequent. And then the skies look thinner, and they say that all of them say that they can have a better vision, because anytime when they look, it seems like there's some cloud. They cannot look through the cornea. But after the surgery for 3 to 4 months, they say that they start to have a better vision. They can look through this sky. It seems like the sky is thinner. Yeah. Thank you.
Еще вопросы? Okay, thank you, Professor. Very interesting presentation. Следующая лекция будет посвящена также шваномам и защите. Да. От профессора Швейцарии Дэниел Роя.
Okay, we're setting up for the next conference. I believe it's Roy Daniel. We'll see in a second after he introduces himself. Yes, I believe it is.
Okay, good evening. I have to thank Professor Sufianov and his team for giving me this opportunity to talk to you about my experience with vestibular schwannoma. Also, I have to congratulate Vuti for an excellent presentation. And on the topic of keeping facial function intact. Now, I'm also going to talk on the same subject, but from a different viewpoint. And the whole change in the paradigm of treatment of vestibular schwannoma is to achieve an excellent facial and, if possible, cochlear nerve preservation. So we are on the same topic, but we are looking at it in a different viewpoint. So I will not go into the detail. We have heard a lot about vestibular schwannomas. At the moment, what is the outcome? And this talk is focused only on the treatment of giant or large vestibular schwannomas. And if you look at the best literature available in the world today, and we're looking at the Hanover group, Professor Sami, and the results for facial nerve for large giant tumors, Hausen-Brackmann 25%. So that's what we are talking about, and that is the, and if you look at 1 and 2 combined, it's another 20%. So this is the best result possible in the world for giant or large vestibular schwannomas. There may be other people who get better, but it's not significantly much better than 40 to 50% of Hausen-Brackmann 1 and 2. Now, if you look at hearing, and this is a series that shows hearing results in small tumors. We're not talking about giant, it's small tumors. And if you look at small tumors, these are 2 centimeter tumors, it is between 16 and 40% of hearing nerve preservation. Now, how can you now improve outcome in large tumors for these 2 functions? What's the evidence from radiosurgery? And don't forget, radiosurgery results we have for more than 20 years now. So this is not a new pathology in which radiosurgery has been used. The long-term clinical and scientific track record is very good. And in the last 20 years, there have been a lot of changes and developments in the technique of how radiosurgery is delivered. And the results have gotten even better. And at the moment, tumor control is in the region of 97 to 98%. And the clinical outcome is less than 1% for a risk of facial nerve. Again, these are for small tumors, not for large tumors. And hearing preservation is in the region of 70%. Now, when you have a large vestibular schwannoma, obviously radiosurgery is not an option. You know that. He comes to you with a vestibular schwannoma. And today, everybody knows the results for vestibular schwannoma everywhere. And they are going to expect the same results from a giant or large vestibular schwannoma. And whatever you tell them, and you tell them Professor Sami's series, they are not going, for them a facial palsy is a facial palsy. You lose hearing, you lose hearing. They look at radiosurgery literature and ask you, why are you not able to do that? And obviously, we cannot treat that with radiosurgery. So we need to find a solution to this problem. What is the problem with radiosurgery? And if you see, it is basically in the dose volume curve. If you have a small tumor, the amount of tissue around that is being irradiated is small. But when you have a larger tumor, you have a larger area and a larger dose which is delivered outside. And that's where the complications come from. What if we have the capacity to reduce the size of a tumor to a tumor that can be treated safely with radiosurgery with excellent results? That would be, in my view, the ideal solution. Now, how do you do that? And that's why we developed this paradigm of a combined approach in which we are planning to keep facial and cochlear nerve, and we are planning to not remove the whole tumor. So the whole surgery is aimed at the facial and cochlear nerve, and it's not necessarily aimed at the tumor. You need to bring a large tumor, make it small. And if in the long term, this result gives the same result as for a small tumor radiosurgery, then we have achieved our objective. So the whole idea of surgery is like this, and all of you know that vestibular schwannoma is surrounded by nerves, 4 of them, 2 vestibular nerves, 1 cochlear and 1 facial nerve, and they can be variably distributed as we have seen before. So the idea of this approach is to leave a thin shell of tumor of 1 to 2 millimeters maximum in the shape of the facial nerve and the cochlear nerve. So only on the facial and cochlear. So it is basically an electrophysiologically guided resection in which all the capsule is removed except for the part which is on the facial nerve and the cochlear nerve. And you just leave it there. You wait 3 months or 6 months. With brain pulsations, a large capsule, as you see in the second on the diagram, it becomes smaller. And in about 6 to 9 months, it becomes a small target. And now this is a target in the major centers in the world. The majority of centers is ideal for Gamma Knife with excellent results. Now, is that possible to achieve it? I'll show you the results that we have had. We have had, look at this large tumor. You have the pre-op scans on the first row. That's the immediate post-op. And then 6 months post-op, you've converted that giant tumor into a small tumor, which is capable of being treated with radiosurgery. And there you can see 1 year later that you have necrosis starting within, and slowly it completely disappears or remains static and does not grow. That's all you want. This patient has grade 1 Hausen-Brackmann after surgery. And again, a similar patient, you see on the first one, a giant tumor. This is at the time of Gamma Knife. This is 3 years post Gamma Knife. You can see that the tumor is shrinking, Hausen-Brackmann grade 1. What do you do when you want to keep the cochlea? And now this we offer only to patients who have useful hearing. That means Gardner-Robertson 1 to 3. And the other patients who do not have that, we do not bother about the cochlea. So this is a patient, you can see the audiogram in the middle, large tumor. Immediately after surgery, you can see that shell of tumor on the facial and cochlea, 1 millimeter thick. And that's your result at 3 months. And it's perfect for radiosurgery at that point. And you have a patient who's got an audiogram that has remained normal 3 years post-Gamma knife. So Hausen-Brackman 1, Gardner-Robertson 1 after surgery. Now, the operative nuances, I was lucky that I was trained in the era in which we used to do total excisions, and I've done that for 15 years. And then when the expectations of patients changed, I had to change my technique. So knowing how to remove a tumor completely greatly enhanced my ability to leave a 1 millimeter nerve on 1 millimeter tumor on the nerve. And that's exactly what you see there. Immediate post-op, you see a 1 millimeter shell of tumor in the shape of the facial and cochlear nerve. Another tumor, you can see exactly the same thing, 1 millimeter thickness. And basically you leave a shell and you keep removing tumor till there is only capsule 1 millimeter thick on the nerve. Well, just a short video. I'm not going to take you through this. Well, it's not playing, so forget it. Okay, what do you do for the internal auditory meatus? Now, in case you're going to leave tumor, that does not make much sense that you go and drill the whole internal auditory meatus, put these nerves at risk. Anyway, that's a part of the tumor that can be easily treated with radiosurgery. So we do not do anything at the internal auditory meatus except in some particular indications. And you see this 80-year-old man who came with a Hausen-Brackman grade 4 before surgery, progressive weakness of facial nerve. And if you see, it's because there is an asymmetric growth of the tumor within the petrous. And you have a kind of sickle effect. You see here, the nerve is being compressed as the nerve comes out of the internal auditory meatus. So this is a very unusual phenomenon. And therefore, what we did is we removed the internal auditory meatus, decompressed the nerve in between, and immediately in a few weeks, he had gone back to facial nerve Hausen-Brackman grade 1. So again, now this is a few months later, he's ready for radiosurgery, and that has been treated. So just to look at some of the results, basically, that's your cochlear nerve that you see there. This is the capsule being taken up to the facial nerve. So all this capsule is ultimately removed. And then the key is to have an electrophysiological mapping. So from outside, the stimulation, you get it at 0.1 to 0.2 milliamperes. You compare that with 1 millimeter of thickness of the tumor. And there, if you get from 1 to 2 milliamperes, then it's approximately 1 millimeter. So basically, it's 1 milliampere equals 1 millimeter. So it's an electrophysiologically guided resection. Now, the smaller the capsule is, better the target for radiosurgery, and therefore better results. I'll quickly show some data. So in 6 years, our institute has treated 270 vestibular schwannomas. Only 13% needed surgery. The rest of them were all small. And therefore, all of them had primary Gamma knife. So we operated a consecutive series of 37 patients. Facial nerve function before surgery, only one patient had Hausen-Brackman 4, and all the others had normal function. Half the group, a little over half the group, had useful hearing. And for these patients, we tried to keep the cochlear nerve. So some of the there were four patients who earlier had Gamma knife. So some of them had pre-Gamma knife treatment. It was given in other centers, and so we could not influence that decision. What is the facial nerve function? All 37 have Hausen-Brackman grade 1, including one recovery. So this is a consecutive series in which we have had normal facial function at the latest follow-up. And cochlear nerve function for the patients with pre-op hearing, it's in the region of 80 to 90%. So we are looking at normal hearing in about 80% of patients who had that hearing before surgery. So look at the volumes. We are looking at very large tumors, maximum diameter. Most of them were above 3 centimeters, some of them giant. And how much of the tumor are you actually removing? And if you look at the group in which facial nerve alone was preserved, so you have about 75% removal. And in the other group, it's about slightly less because you're leaving more capsule on another nerve. And the results of Gamma Knife, the mean duration approximately 6 months between the two treatments, and the mean follow-up now we have close to 2 years. Now this is the major problem with the study. We need a lot longer follow-up to say that what we are saying can be believed. We have had no new cranial nerve deficit. One patient needed a shunt. We have had 3 failures in this group, and all three patients were young. And all of them were in the early part. So basically the technique of leaving a thin capsule evolved with time. And all 3 of them, we ended up offering the same approach. We did the combined approach again. We did not completely remove it. We left tumor again on that and again treated with Gamma Knife. So a second Gamma Knife, so second combined approach after surgery. Now this is not a new technique. There have been groups that are looking at it. So basically there are 2 philosophies. One philosophy is that you try to remove the whole thing, and if it gets a little adherent, you leave it. That's one way of looking at it. The results are not all that great in this approach. The other approach is reported from Osaka, Professor Ibai. He looked at the literature. He was one of the pioneers of this technique. And if you look at it, the results are very good. So if you plan to remove subtotally, your results are likely to be very good. So in conclusion, I'd like to say that this approach has excellent functional outcome. We have had no facial palsy. All of them are Hausen-Brackmann grade 1. Very high level of hearing preservation for the people who had hearing before surgery. So this represents a shift of focus. In the microsurgery, it's not as easy as it sounds. It's not easy to leave 1 millimeter thickness all over the nerve. And also in Gamma Knife, you have to also changing your plan. It's not like treating a small tumor to start with. So there is a learning curve for the Gamma Knife surgeon and also the microsurgeon. But it helps you meet the expectations that patients have when they come to us today, because the functional results are as good as radiosurgery. Thank you very much.
Thank you, Professor. Okay. Questions? Вопросы? Maybe yes. Yeah.
When you do a Gamma Knife for meningioma, you don't see the answer. You see the same tumor is the same size. They say that you change the history, that the tumor starts to grow slowly or doesn't grow. But you do the CT and MRI, the tumor is there. Sometimes decrease a little bit, sometimes not. In the acoustic neuroma, in schwannoma, you can see the difference with Gamma Knife. With radiation therapy for Gamma Knife or radiosurgery, don't need to be Gamma Knife. Can be. You see the difference. But the results, the final result, I don't know if it's so good that we imagine. Last week, I was in Kuwait City, Kuwait, Arabic, okay? As a visitor and one from the government, they have a program there. We do surgery and we go to the outpatient clinic. In this clinic, we see the patients. Had 4 cases treated with Gamma Knife for acoustic neuroma. 2 intercanalicular, a little bit larger. All of them are deaf.
All of them are?
Deaf, completely deaf. Lose the hearing. I'm not talking about the surgery saved the hearing. I'm talking about the Gamma Knife always is not always saving the hearing. It's not the best treatment for everything. You do Gamma Knife, you save everything. The second thing, the safest point to remove the vestibular schwannoma is inside the canal. You know why? The tumor is protecting the nerves. The facial nerve and the cochlear nerve are anterior to the tumor. When you open the canal, you're not making any trouble with it. Now, there is a patient, they changed it for patient with neurofibromatosis. That's very, only hearing. Okay? the surgery that the people are doing now, it just open the canal and leave the tumor. The nerve can breathe. Give some space for the nerve. See, I think this is a good technique to remove partially, if you can do a central radiation or just control. But it's not the answer, only the answer. I'm very worried. In the last American meeting, there was the Lexcel company, the Gamma Knife. They show the advertise a big poster. The small meningioma of the posterior fossa, fixed in the tentorium. Very small attachment. Was open the retrosig, take CSF leak, the cerebellum go down, you coagulate there, the tumor come out. It's great for radiosurgery. Radiosurgery is good for some disease, but not to everybody. You cannot say because the Gamma Knife, you treat everything, you'll be safe forever. And the other thing is very rare, but radiation give tumor. The last president of the Central Bank of Brazil had a small acoustic neuroma. He went to New York. He treated his small tumor with Gamma Knife. He dies 4 years later with GBM in the temporal area. Very rare, extremely rare. What's happened?
Well, I'd like to respond to your comments. It's a different philosophy of treatment. And I view radiosurgery just like the bipolar. It is one of the techniques in neurosurgery. I did not say that it was the miracle treatment for everything. So I think radiosurgery should be used with microsurgery for the diseases in which to help our patients. And this should be based on literature, based on evidence. Now, there was a recent study from UK published in which they have a registry for tumors. Every tumor diagnosed in the United Kingdom is under a registry. And they compared the results of Gamma Knife treatment. And they found that the incidence of producing a second tumor is not more than the normal population. So your chap who had a glioblastoma, another guy on the road also develops a glioblastoma. We treat hundreds of glioblastoma every day. It does not mean all of them had radiosurgery before. So at least the registry showed that the incidence of having a second tumor is not more than the normal population. We can only go by what is in literature, and we cannot look at anecdotal cases and decide how we treat our patients. I mean, that's my view, but it's a different philosophy, and I'd love to discuss with you later.
Окей. Вопросы? Okay, thank you, Professor. Okay. Okay, no. Yes. Now finish and go to bus, go to restaurant. I think show must go only in restaurant. Yes. На этом сегодняшний закончен наш рабочий день. Так что сейчас автобусы уже стоят, все ждут, то есть ресторан у нас уже там тоже заждался. Перенесем туда уже все разговоры, общение. Попрошу сдать все переводчики обязательно, хорошо? Это очень важно. Спасибо.
Спасибо.
Okay, Simon, I think that ends the broadcast. I guess there's a change in the schedule. Dr. Sufianov apparently is not going to give his presentation. I think they're kind of running late. So I think that's it.
Okay.
And we'll wrap this up formally. Thank you for joining us for the Tyumen Russia Skull-Based Surgery Conference from Tyumen Russia. And we'll continue this in about for the next session, on the Saturday session, which starts at 8 o'clock Russian time, which is 11 o'clock Eastern Standard Time. I don't know what time it is in Japan. Okay, Simon, we'll see you at the next session.
Thank you very much.